Facial anatomy and conditions. Common facial conditions include zygomatic fractures, maxillary fractures, mandibular fractures, and temporomandibular joint dysfunction and dislocation. Zygomatic fractures occur most often as a result of direct impact. They are the third most common facial fractures. Signs and symptoms include obvious deformity, swelling, and ecchymosis or bruising around the eyes, epistaxis or a bloody nose, and or diplopia, which is double vision. Management should include immediate referral to a physician. You can also apply an ice bag, but do not compress the injury. Maxillary fractures occur from a severe blow to the upper jaw. They are the fourth most common facial fracture. Signs and symptoms include deformity or the appearance of a very long face, malocclusion, which is where the teeth do not meet properly, pain with chewing, and epistaxis and or diplopia. Management should include immediate referral to a physician, having the athlete sitting forward to maintain the airway. If an athlete leans back, the blood may go down the throat and into the stomach. When blood enters the stomach, there's a good possibility of vomiting, which wouldn't feel very good with a fracture. You can also apply an ice bag, but do not compress the injury. A Lefort's fracture is a mid-face fracture. This includes getting hit to the nose and often involves more than one bone. A Lefort's fracture can potentially be very serious. A mandibular fracture can occur from a direct blow to the lower jaw. This is the second most common facial fracture. Signs and symptoms include obvious deformity, malocclusion, changes in speech, oral bleeding, swelling, and ecchymosis. They may also have what's called a positive tongue blade test. The tongue blade test is performed by placing a wooden tongue blade between the teeth and then trying to pry the jaw open. If someone has a mandibular fracture, they are not going to be able to hold the tongue blade between their teeth, or you will easily be able to pry their mouth open. Management should include immediate referral to a physician, immobilization with an elastic bandage, and having the athlete sit forward to maintain the airway. Mandibular fractures are most commonly occurring when the mouth is moving, so there's also a possibility of a mandibular dislocation at the same time. An articular disc divides the temporomandibular joint into two separate compartments, the superior compartment and the inferior compartment. The superior compartment is responsible for gliding of the joint and creating the movements of protrusion and retraction. The superior compartment is responsible for gliding of the joint or creating the movements of protrusion and retraction. The inferior compartment is responsible for hinging the joint or creating the movements of opening and closing. The temporomandibular joint has a high degree of mobility. Common signs and symptoms of temporomandibular or TMJ dislocation include obvious deformity, including when obvious deformity where the mouth may even be stuck open, such as in the picture on the slide and in the x-ray, inability to move the jaw, severe pain, headache, and possibly nausea. When managing TMJ dislocations, it's important to refer the participant. When managing a TMJ dislocation, it is very important to refer the patient immediately and to suspect a concussion. TMJ joint dysfunction occurs with displacement of the disc. Common signs and symptoms include headache, earache, neck and shoulder tightness or pain, clicking in the jaw, especially during movement, malocclusion, hypermobility, which is too much movement, or hypomobility, which is too little movement. Management for TMJ dysfunction should include strengthening if the problem is hypermobility, joint mobilizations if the problem is hypomobility, ice, rest, and possibly temporary immobilization. Sometimes temporary immobilization includes wiring the jaw shut. Talk about the ultimate liquid food diet. If the mouth is not wired shut, placing the patient on a soft diet may help decrease some of the irritation at the disc. Nasal conditions include nasal epistaxis and nasal fracture. Nosebleeds can be very dramatic and frightening. Luckily, most nosebleeds are not serious and can be handled fairly easily. They're divided into two types depending on whether the bleeding is coming from the anterior or the front of the nose or the posterior in the back of the nose. Anterior bleeds make up more than 90% of all nosebleeds. The bleeding usually comes from a blood vessel at the very front part of the nose. Anterior nosebleeds are usually easy to control and can be handled by either by measures that can be performed at home or by a doctor. Posterior nosebleeds are much less common than anterior nosebleeds. They tend to occur most often in the elderly. Bleeding usually comes from an artery in the back part of the nose. These nosebleeds are much more complicated and usually require admission to the hospital and management by an ear, nose, and throat specialist. Nosebleeds tend to occur during winter months and in dry, cold climates. They can occur at any age, but are most common in children ages 2 to 10 and adults aged 50 to 80 years old. Most commonly, trauma to the nose triggers a nosebleed. Trauma to the outside of the nose, such as a blow to the face, or trauma inside the nose, such as nose picking or repeated irritation from a cold, can cause nose bleeding. Bleeding usually occurs only from one nostril. If the bleeding is heavy enough, the blood can fill up the nostril on the affected side and overflow through the area inside the nose where the two nostrils merge, and spilling into the other nostril, which causes bleeding from both sides. Blood can also drip back down the throat and into the stomach, causing the person to spit up or even vomit blood. Signs of excessive blood loss include dizziness, lightheadedness, confusion, and fainting. Excessive blood loss from nosebleeds are rare. A small amount of bleeding from a nosebleed requires little intervention. A common scenario is when a person with a cold or sinus infection blows his or her nose vigorously and notices some blood on the tissue. Avoiding any more vigorous nose bleeding, sneezing, or nose picking is usually enough to stop the bleeding from getting any worse. If you do have a nosebleed, remain calm. Sit straight up, lean your head forward. Tilting your head back will only cause you to swallow more blood. Pinch the nostrils together with your thumb and index finger for approximately 10 minutes. You will have to breathe through your mouth during this time. Have someone time you to make sure that you do not release the nostrils any earlier. Spit out any blood that flows into your mouth. Again, swallowing the blood may make you vomit. Once the blood is stopped, do not blow your nose. It's created a clot inside the nose. As long as that clot is in there, then the bleeding should be stopped. Nasal fractures are the most common fracture. Nasal fractures are the most common fracture of the face. They are usually caused by a direct blow to the nose. Common signs and symptoms include obvious deformity, a flat or asymmetrical or even saddle-like appearance, immediate swelling, and epistaxis. The management of nasal fractures includes immediate referral to a physician, control of the bleeding, and an ice bag to the face without any compression. Dental conditions include tooth fractures and tooth subluxations and dislocations. Different parts of the teeth can fracture. An uncomplicated crown fracture includes a fracture involving the enamel, or the most outer layer portion of the tooth, and it may not cause any symptoms. It can also be a fracture which extends into the dentin, which will result in pain and sensitivity to cold and heat. A complicated crown fracture is a fracture which exposes the pulp or the root of the tooth. A complicated crown fracture results in severe pain and sensitivity. If someone has sustained a tooth injury, refer the individual to a dentist as soon as possible. Injuries to teeth may require capping, a bridge, or even a root canal. If a tooth is knocked out, try to reimplant it as soon as possible. If you are not successful, save the tooth. How do we save the tooth? Well, we can place the tooth in milk, saline, or even a Save a Tooth kit. We can also place it between the cheek and gum of the person to keep it in the same environment of the mouth. However, there is a risk of swallowing the tooth, and let's be honest, if a tooth is swallowed, there isn't any purpose in trying to retrieve it, to try to reimplant it in the mouth. No one will want it in their mouth after all the places it's traveled anyway. Common signs of tooth dislocation include pain and bleeding. Refer the person to a dentist as soon as possible with the tooth. Control bleeding and suspect a concussion. Ear conditions include auricular hematoma, rupture of the tympanic membrane, otitis externa, and otitis media. Auricular hematomas are also known as cauliflower ear. They are common in boxing, rugby, wrestling, judo, and any sport in which headgear is worn. The headgear creates a friction-type injury similar to a blister as it moves around the ear tissue. The hematoma forms and then the tissue scars. In certain cases, auricular hematomas can actually impair hearing. It can close the ear canal and cause some difficulty. Common signs and symptoms include severe pain and throbbing, coagulation or pooling of the blood, which results in a hardening of the tissue, and a fibrosis, which leads to keloid formation or scar formation. Coagulation or pooling of the blood, which results in a hardening of the tissue, and a fibrosis, which leads to keloid scar formation. To manage auricular hematomas, apply ice for 20 minutes. If it is not better, refer to the physician as it may need aspiration or drained and a pressure bandage. Once an auricular hematoma looks like it does in the picture at the upper right, unfortunately, only surgical procedure can actually remove that hematoma. It is now a keloid scar formation and is blocking part of the ear canal. We may have to have elective surgery to remove this tissue. The tympanic membrane ruptures are commonly seen in collision sports, water polo, and diving. A patient will complain of a loud pop followed by pain in the ear, possible bleeding from the ear, tinnitus or ringing in the ear, nausea, dizziness, and possibly hearing loss. Management for a tympanic membrane rupture includes referral to a physician. In most cases, the eardrum will typically heal itself spontaneously, but it does need to be monitored for possible infection. Otitis externa is commonly known as swimmer's ear. It is an infection of the outer ear canal. During bathing or water sports, water can get trapped within the wax within the ear. During bathing or water sports, water can get trapped in the ear. A bacterial infection is more common than fungal. We need to refer our patients to physicians to determine what type of infection is present. We need to refer our patients to a physician to determine which type of infection is present. If the individual is going to continue to spend a lot of time in water, custom earplugs or eardrops may be used to prevent further infection. Otitis media is a middle ear infection. It could be a result of a bacterial or viral infection. It is best to refer individuals to a physician for possible antibacterial therapy. Air travel is not recommended in severe cases as the eardrum may rupture. Eye conditions include periorbital ecchymosis, foreign bodies, conjunctivitis, corneal abrasions, corneal lacerations, detached retina, and orbital blowout fractures. A periorbital ecchymosis is a common black eye. In most cases, there isn't a lot of treatment that needs to be performed. And most cases, there aren't a lot of treatments that need to be performed, and they don't turn into serious conditions. We need to control swelling with an ice bag without compression to the eye. Refer to an ophthalmologist to rule out other conditions. Foreign bodies within the eye. These pictures are hard to look at. If the object is not embedded or is not on the cornea, we can attempt to remove the object by flushing the eye with either water or saline. If the object is embedded or is on the cornea, refer immediately. Try not to let the patient rub their eye, as any foreign body can then scratch the eye and damage it further. A physician might conduct a fluorescein test on the eye to track the damage of the eye. Orange drops are placed on the eye, and then a blue light detects foreign bodies or any eye damage, particularly to the cornea. Conjunctivitis is an inflammation of the conjunctiva, or more commonly referred to as pink eye. Eyes will commonly itch, burn, and water, and may develop a pink eye appearance. It is very important to remember that this condition is highly contagious. Refer to a physician to get eye drops for the condition. Water sport athletes should not get back into the water until their symptoms have completely resolved, as the bacteria can actually be transferred in the water. A corneal abrasion or laceration results in damage to the cornea. Signs and symptoms include pain and watering, feeling like there is something in your eye, photophobia or sensitivity to light, distortion, and possibly displacement of the pupil. To manage corneal abrasions, we should refer them to a physician. Do not place pressure on the eye. Placing 2 cups over the eyes can actually allow the eyes to rest and be in protection. If you are going to protect one eye, you need to protect both eyes because both eyes move at the same time. Eye drops may help with symptoms. The retina may separate from the retinal pigmented epithelium, resulting in a detached retina. This is more common among athletes who have myopia or nearsightedness. This is a difficult injury to diagnose as there are few signs and symptoms and could be painless. The biggest complaint after detached retina are floating specks, flashes of light, and blurred vision. An athlete might describe it as a curtain fell over their eye or they lost certain parts of vision. A detached retina is a very serious concern and should be immediately referred, as surgery is often required to weld the retina back on the eye. An orbital or blowout fracture can occur when a blunt force pushes the eye posteriorly. This increased intraorbital pressure breaks the orbital floor. Signs and symptoms of a blowout fracture include diplopia, numbness, recessed or downward displacement of the globe of the eye, absent eye movement. A blowout fracture is an emergency condition and should be immediately referred. Ice bags may be used with no additional pressure to the eye. Typically, surgery is used to fix the break of the orbital floor. Many facial injuries can be prevented by utilizing the correct protective equipment. Sometimes they are used as a fashion statement, but they can also be used to prevent injuries or protect structures after an injury has occurred.